Thanks for joining us on What Matters This Week this Sunday. I am joined now by Dr. Kevin Gallagher, Chief Medical Informatics Officer at Hudson Headwaters Health Network. Sir, I appreciate you joining us.
It's a pleasure to be here. Thanks for having me.
We're here to talk about the expansion of telehealth coverage, really in this age of the pandemic. A year ago, probably people would have laughed at us, but here we are, and talking about doctor's visits online. You have about 21 health centers in the North Country. Set the stage for us. Where was telehealth in January or February of this year?
January, February is very few visits were being done that way, mostly in the behavioral health arena. There was a lot of billing and regulatory implications that made it challenging to offer this kind of service. And then along came the pandemic, which really started flaring up in March. And we began to really evaluate how we could use telehealth to provide service for our patients in a time when it was difficult to otherwise obtain healthcare services.
And how soon into March, let's say, did you have to act on this?
So we began strategizing a way that we could use our electronic health record that we use now to manage patients and look at a platform that we could use to be able to provide that virtual video connection with patients. And we really started piloting that process. We started actually measuring our productivity with that on March 23rd. So I kind of used that date as roughly when we fully implemented it and began to deploy it throughout the network, all 21 offices.
And I imagine there were some bumps in the road early on. What were some of those challenges like? And cost, I imagine, was one of them.
Sure. We initially used Zoom to do our visits, and we had to figure out ways to email patients links to the meetings. And we tried to really make sure that we did a phone call beforehand to make sure that patients who were brand new to this could get Zoom set up on their tablet or computer or their mobile phone. So there was a lot of kind of technical setup that was a barrier. Then we also had to train all of our nurses and providers and patient service advocates in the front office about how to really talk this up, be an advocate for it, how to do the workflows correctly, and then how to become efficient with it and get patients to do it. And then once you had a couple of visits go smoothly and you got to see the patient satisfaction on the other side, it just began to grow.
Let's talk about some of those safety and security issues that you alluded to. How do you and the patient kind of work that out? And then how do those health records play into it as far as getting access?
So the health records really haven't changed. When we're managing the patient, we're still using the same secure electronic or EMR that we've used for several years. So that part of it didn't really change. It was then how do we layer on our computer screen when we're looking at the patient's chart and their health information, how do we get an image of the patient and sound where we can have that virtual visit? So it wasn't much of a security issue in terms of the health information and the EMR. It was really just figuring out how best to have the connection with the patient and their visual image, plus having their chart and information in front of you, and then how to make that interaction really seem natural and like it was happening right in front of you.
Did that take some, I guess, a learning curve, right, on how to make it seem like really you're right there when there's miles between you?
Yeah, we learned a lot. Initially we thought, oh, everybody should have two monitors, and then you can have the EMR on one monitor, and you could have the video of the patient on the other. And then as we started doing it, we began to realize from patient feedback actually that, boy, it looks like you're looking sideways and you're not looking at me because you're looking at the health record. And so we got a lot of feedback that we used to tweak how we manage that. And at the end of the day, we really ended up using our laptops to do both. And we're able to do that pretty efficiently. But yeah, lots to learn for sure.
Definitely. And we're still learning, all of us. There were some government restrictions, correct, that really needed to be put in place or lifted to allow for this to happen, as to which doctor can I talk to online? And does it need to be, my family practitioner, or can I go somewhere else because if I need help right away?
Sure. So, some of the regulations that were in place that made it challenging before the pandemic that were lifted, really provided greater access for patients. So, we didn't need to have an established relationship necessarily with the patient. So we could see a brand new patient through a video visit, which was something new. We could see patients across other state lines. So the place where the patient was located, originally you had to have a license to practice there. So, if we had some of our patients who are snowbirds who live in the North Country in the warmer months and then go to Florida or somewhere south for the winter months, if they were in Florida previously to manage or be able to do a virtual visit, you also had to have a license in Florida. So that got eased up a little bit, which did help some access to care. Also, your place of origin, you needed to be in your health center when you were initiating a visit. That got lifted as well, which did certainly provide some flexibility with maybe being at an administrative office or not necessarily in the health center where you might have sick people in person where you're worried about the spread of COVID. We were able to kind of sequester our care and get it into a different spot. So that, along with the ability to have insurance companies reimburse the work that you were doing, also really helped support this effort and get it scaled out at a larger level.
Do you hope some of those may actually continue with telehealth even when the pandemic is over? Would that help you?
Absolutely. And CMS, Center for Medicare Services, has released some preliminary information on their 2021 fee schedule. And it does look like what they're proposing keeps some of what's in place for providing telehealth intact, even post-pandemic. So I'm really encouraged that hopefully this will continue and telehealth will continue to be a part of how we provide a portion of our healthcare moving forward for years to come.
Let's talk about some of the rural challenges, because not only are some of your patients probably a year ago traveling quite a distance perhaps to get to you because of the location of the North Country, but also you're dealing with broadband and connectivity issues.
Sure. So we have several areas throughout our health catchment area where there is no broadband coverage. And so we partnered with a few of the internet providers and actually created mobile hotspots in the parking lots of our health centers to allow for that. So patients could potentially drive to the health center and do a virtual visit from their car and not necessarily enter in the building. I mean, there was really a heightened level of socially distancing and minimizing exposure within the health centers. So that became a really nice way to get around some of that. And we also partnered with some of, in some of our areas, with the home health agencies, where we were able to have individuals who are patients that were in the home and wouldn't have otherwise had access to broadband or a smart device. And through some of the home health agencies, we're actually able to get the telehealth visit started and collaborate with us on that. So that was one of the creative ways we looked to overcome some of those limitations that we've had in the North Country with connectivity.
Doctor, lay it out for us. Which is more beneficial for as far as treating a patient? When do you want to see them in person? When do you draw that line?
So that's a really good question. I think if you go back, so to best answer that, I'm gonna pretend we're back in April of 2020, and people are really not entering the health center, and we provided them the way to have a virtual visit. There were several instances where the outcome of doing that virtual visit led to, what, we really need to see you in the office. I can't, correctly manage what you're presenting with without seeing you in front of me, examining you hands-on. And so we're gonna have you come into the health center, in the next, within that day or a following day. So it's a difficult question to say, where do you draw the line? There's some clinical judgment that happens there, but you can glean enough information from speaking with a patient, seeing their facial expression, how they're answering your questions. You can quickly kind of make a decision as to whether or not this is something that you can handle right here with with a virtual visit, or if we need to convert this into an in-person visit. And then we took a lot of time to make sure that those in-person visits were safe. We have screeners at the doors within the health centers. We have them, ask basically all the same questions around symptoms of COVID. So we really did like an in-person attestation before we would even let patients into our waiting room to then be seen. So we kind of had that second layer of trying to really be safe and protect our patients. So when they did come in for in-person visits, we were able to do that and make everyone feel comfortable.
Given no doubt the population that you are serving, and possibly the older population, do you have concerns that some people will only see a doctor in person, that, this technology, either they don't think they can manage or that it's foolish? Do you deal with that on a daily basis?
Yeah, absolutely. I think for a variety of different reasons. Some of it is, just not having experience using the technology, not reaching out to family members who might be able to help them. Some people, I think, for some folks, I think going to the doctor is, it's an experience. It's a reason to leave the house. It could be a social outing. It could be a couple of errands that you run if you're living really far away from the health center. So I think for a variety of different reasons, it's been such the way that patients have experienced going to the doctors for such a long time. For some, it was a really easy shift to make. And for some, it took a lot of explaining of how this could really complement healthcare delivery.
And doctor, where do you need help right now? Where do you need maybe the government to step in to give you an influx of funding to help keep this continuing at the level that you are right now?
I think that increasing the broadband coverage throughout the North Country, where we don't need to then ask people who don't otherwise have a means to have this type of virtual visit to drive 20 miles to the health center to hit a mobile hotspot, where they can do that more conveniently within their homes. I think that will go a long way. I think the continued advocacy with the insurance companies for recognizing the work that you're doing with these virtual visits and continuing to reimburse them at a competitive level will go a long way to keeping this viable. I think we're in a really good spot now. We have a integrated solution that ties right into our EMR now to deliver telehealth. So I think that we, as a health network, really have that foundation in place from a technology perspective, where we're in a good spot with that. I think it's really more providing more seamless access for the patients.
Okay. Dr. Kevin Gallagher, really appreciate your time this afternoon. Thank you.
You're very welcome.